Okay.
My name is Karn and my topic is subacromial impingement. Subacromial impingement syndrome is a compression of the rotator cuff and the subacromial bursa against the anterior-inferior aspect of the acromion and the coracoacromial ligament. This is a painful condition that is most commonly seen in athletes, but more specifically overhead athletes like baseball or swimming. And shoulder impingement syndrome and glenohumeral joint instability are the most common shoulder disorders that people going into the doctor to see what's going on. There are two classifications of subacromial impingement. Structural is caused by the narrowing of the subacromial space resulting from a reduction in the space due to like a bony growth or soft tissue inflammation. And then functional is caused by the superior migration of the humeral head, which is caused in the weakness or muscle imbalances. So that's pushing the humeral head up, causing that decreased space. There's potential causes for this is, like I said, dysfunctional of the glenohumeral and scapular kinematics, degeneration and inflammation of the tendons or bursa, postural dysfunction, weak rotator cuff and scapular musculature, and capsular laxity or tightness. The clinical tests used for this are Hawkins-Kennedy, which is passively flexing the shoulder to 90 and then fully internally rotating the shoulder, and near sign, which is passive flexion of the shoulder while the scapula is stabilized, and pain is a positive sign for both of those. And then they found a cadaver study that went through and found which muscle would be causing the pain during different motions. And it found that if the supraspinatus is associated with the impingement, internal rotation and abduction would be painful. And if the subscapularis is associated with the impingement, then flexion and internal or external rotation may be painful. And if the infraspinatus is associated with it, then external rotation and extension may be painful. Rehabilitation for subacromial impingement generally consists of the use of modalities, strengthening, motor control techniques, stretching, joint mobilizations, manual techniques, patient education, and functional mobility retraining. There is a surgical option for this, but everybody should try to do the rehabilitation aspect for a good number of weeks before they decide to go into surgery. That's it. Any questions?